Testing 1 2 testing 1 2.
You need me to test anything? Are we good? Just go ahead and get started. Okay. Well, good afternoon. I'm delighted to be here. My name is Ella Bowman. I'm the Chief of Geriatric Medicine at the Birmingham VA, and I'm also the Fellowship Director and the Director of Geriatric Medical Education at UAB. And I'm doubly thrilled to be here today because the story that I'm going to tell today actually started at St. Vincent Hospital. I won't tell you how many years ago, but I trained as an internal medicine resident at St. Vincent Hospital in Indianapolis, and that was followed by my geriatric medicine fellowship. And then I ended up staying there for 16 years, so what started out to be just do my 3 years of residency, then move back home, turned into a very long stint. And I moved down to to Birmingham, Alabama about 5 years ago, so I've been in this role. I'm a hospitalist by training, so there are many geriatric functional syndromes that are near and dear to my heart, as well as sometimes very frustrating when patients present with a variety of issues. But delirium is probably one of the ones that has challenged me the most throughout my professional career, because if you've seen one case of medical delirium, you've seen one case of delirium. There is an incredible amount of heterogeneity. So my subtitle is Why Pleasantly Confused Isn't So Pleasant. And by the end of the talk, I hope to convince everybody watching to never put that quote in a chart again. It used to be a benign thing to see a little old lady in the hospital and write pleasantly confused. There is nothing pleasant about a hypoactive delirium. So we're going to talk about that. I have to maintain my animation given that there's nobody in the room here with me, so I will try not to wave my arms too much. Sometimes I get carried away, and I'll also keep track of the time as we go. But I am very happy to be here today. I have no financial relationships to disclose. I will not discuss any off-label use of medications or investigational use, and my opinions are mine alone and don't reflect that of the Veterans Administration or the UAB School of Medicine. So the objectives over the next hour are that everybody at the end will have a better understanding of the epidemiology of delirium, to identify the clinical features of delirium, and especially in older adults. Enhance your ability to distinguish delirium from other mimickers that you might see in the hospital setting, including dementia and depression. That's what I call the 3 Ds of geriatrics. And identify the risk factors for developing delirium. And then most importantly, the roles of our interprofessional team that surround us every day, but they might be maybe less visible, especially with the pandemic under which we're operating right now, which has really challenged those of us who do inpatient care as far as delirium prevention goes. And I'll hit on that a little bit at the end. You'll notice that I'll get 90% through the talk and I won't mention a single medication, and that is very purposeful because there is a very limited role of medication in preventing or treating delirium. So I always like to start out with something that's very relevant. And Mr. M is a patient that I saw within the last year when I was working at the VA. He is a 71-year-old Vietnam veteran. He was admitted to the medicine wards with an acute confusional state, as well as some audio and auditory and visual hallucinations. In his history of present illness, it was noted in the chart that he was weak and he couldn't get out of the chair for several days. And his confusion really escalated over about 3 days prior to arrival. His past medical history looks like a lot of Vietnam veterans that I see at the VA. Type 2 diabetes, he has peripheral neuropathy, sleep apnea, PTSD, prostate cancer, major depression, generalized anxiety, chronic kidney disease, chronic back disease, degenerative joints. So he had a lot of things going on that really aren't just representative of veterans, but really representative of a lot of elderly patients across our healthcare system. Socially, he had gone to vocational school. He was a carpenter. He never used any substances, and he wasn't even a smoker. He had been disabled for years, according to his wife, due to multiple spine surgeries that he had experienced in his 30s and 40s. His wife of 48 years told me that he had pretty much spent the last couple decades in this easy chair in their living room. They had 3 kids, and a very remarkable family history of both parents and many siblings with dementia. Truly remarkable. Something like 5 or 6 brothers or sisters all had been diagnosed with dementia. And I don't mean that as a red herring to point toward a diagnosis, other than to say that he certainly had risk factors for confusion. These are his medicines that he is on at home, and I'm just going to kind of highlight them here just so you can make eye contact with all of the names of the meds, and then we'll talk a little bit more about the doses and what all this means in the next couple of slides. So when I was asked to see him to rule out Lewy body dementia, I think this was primarily due to the fact that he was not only confused on presentation, but at his age of 70-something, he was relatively young in the eyes of the medicine team that saw him. We're used to often taking care of 80, 90-year-olds and up in the hospital. So to them, they thought, well, maybe this is an early onset, something really funky that the geriatrician ought to see him for. Findings on exam, he was very weak in the trunk and in the quads. He had some mild acute kidney injury. Mildly low B12, 287, but nothing too terrible. CT of the head without contrast was negative. They had ruled out urinary retention and fecal incontinence, something that we teach and beat that drum when people come into the hospital, that whenever they're confused, you have to rule out the bowel and bladder disturbance. They had done all of that before calling me. They had held almost all of his medicines or decreased the doses significantly. And then the good med student on their team on hospital day 2 did a St. Louis University mental status exam. That's often an exam that we use, especially within the VA environment, because it was developed and validated on veterans at St. Louis University. A normal score is 30. It's pretty comparable to a mini mental status exam where they're both 30-point exams. It looks at a few different functions than the mini mental, but it's a pretty good approximator. His score was only 10, and that's pretty deplorable for a man that doesn't have any kind of cognitive diagnosis. So he was getting an echo when I walked into the room, and he and his wife sat there with me, and we talked for a good 40 minutes. And that was a good thing, because he came back to the room after I got so much history from her, and I realized immediately he is completely disoriented. He is rambling nonsensically, and I'm not going to get anywhere upon questioning him. So things that his wife endorsed while he was out of the room were things like dizziness, falls, both urinary and fecal incontinence, but that dated back to a prostate cancer surgery and treatment years ago, so nothing new. He had chronic trouble walking stemming from his back pain. He never went anywhere without a rollator, one of those nice little wheeled walkers with handlebars. But he's had remarkable memory and driving problems, and get this history. He has been driving backwards, up and down the wrong way in the street. He's actually plowed over neighbors' mailboxes, but not a soul has ever told him to get a driving eval or even consider stop driving. He doesn't tolerate his continuous positive airway pressure, his CPAP, so he never wears it, and because of that, he doesn't sleep so well. He spent, like I mentioned, the last 40 years in the same chair, seeing and hearing his son's dog in the hospital room ever since he got admitted, and because of that, it kind of fueled his feelings that we were actually in his living room, because he couldn't fathom that this dog would have followed him anywhere, and being that he kept seeing the dog, he was convinced that we were in his living room. So the question is, why did he get confused now? And this is where I always love to open it up to the audience, and I can't do that today, so I'm just going to keep on going. Upon extensive questioning, and this is where geriatricians can be somewhat cynical in when we think we have all the history, we just keep on asking questions. And in a couple more layers of questions, I found out the wife mentioned offhandedly, well, you know, whenever he gets a little funny, I tell him to use his CPAP. But in order to tolerate it, I have to give him something to help with head congestion so that he can get through the night without ripping it off. And that is the key to everything else that will follow. But I'm going to save that until the end of the talk. So defining delirium. I love this painting. Many of you, if not everybody, will recognize this, but to me, this is pictorially synonymous with how your patient with delirium often feels. And if you've taken care of a lot of cases of delirium in the hospital, this might represent how you feel when you have one of these patients on your service. So what this delirium literally means, if you trace it back to the Latin roots, it is an acute disorder of attention and global cognition or awareness that affects your memory and your perception. And there's a little more to the definition that I'll evolve over the next few slides. But it comes from the Latin lyra, and a lyra is the ridge left by plowing. And the verb delirare came to mean somebody who acted drunk when he was trying to plow his ridges, or a farmer that could not make a straight ridge. So delirare literally means off the track or off the rails. And there have been many synonyms which add to this confusion over the years. I've seen everything in the chart, from acute confusional state. One that we've often used in our own practices maybe, or see regularly, is acute mental status change, or AMS, organic brain syndrome. The international classifications of diseases used to have one called crazy, not otherwise specified. What a horrible term to write in a chart to describe your patient, because it really doesn't tell you much of anything other than the person is off the rails. I love this one just because it sounds wacko, the subacute befuddlement, but that is a term that has been used over the years to describe somebody that's delirious. Probably my favorite one from a billing and coding perspective, as well as truly documenting in the chart what the patient has, is either a toxic or a metabolic encephalopathy. We'll talk about that a little bit later. But basically, a toxic or metabolic brain failure. And that's the kind of terminology that I use with my families. That this is like heart failure or lung failure or kidney failure, but it's brain failure. So according to DSM V, delirium is a disturbance in attention hallmarked by reduced ability to direct, focus, and sustain your attention and your awareness. It is accompanied by change in cognition, so memory deficit, disorientation, language disturbance, or a perceptual disturbance that's not better accounted for by something else, such as dementia. It, by definition, is acute, so it represents a change from baseline, and it's fluctuating. So it can fluctuate from day to day, from hour to hour, and I've even had people crystal clear as I walk in the room and be completely confused as I walk out, or vice versa. So it can literally come in waves and wax and wane right before your very eyes. So this is often when when your resident tells you on rounds that the patient is alert and oriented times 4. An hour later, you step in the room and the person is ripping off everything in sight and saying, Eisenhower is the president. So that is sort of the hallmark of a key, raises my suspicion that this patient very well may have delirium or encephalopathy. And then finally, you have to prove that it's not caused by something else. So by definition, delirium is a consequence of either a condition, a drug, a medication, or sometimes multiple insults hitting your patient all at once. So this is really common. And again, this is where I have my query of everybody in the room, and I ask everybody, how often do we see this? And just, my giveaway, which is in the next slide, is that usually the numbers that pop up here are more common than what we all think. So on the medical service, up to 1/3 of patients will be delirious at any given time. And of course, this can vary from medicine service and hospital system to hospital system, but on average, about 30%. Up to half of surgery services can exhibit delirium in the hospitalized elderly. If you have an intensive care unit that is 10 beds on any given day, 7 out of 10 of those patients are going to be delirious. And then when they leave the hospital today and go down the street to rehab, they're not better tomorrow. So tomorrow when we see them in post-acute rehab or skilled care, the incidence of delirium is still up to 60%, which is a crazy high number. When you think that most patients who go to subacute rehab go to a nursing home where they might not be seen by a doctor for several days. So this can be terrifying if you're a family member sending your mom or your dad or grandpa off to skilled rehab in this situation. In palliative care settings, especially inpatient hospice units, the numbers can vary up to 90%. So, and that's not all surprising, especially on an inpatient hospice unit. So why do these numbers keep me up at night? And also provide an amazing amount of job security. So delirium is often unrecognized, if it's recognized at all, or it's recognized late. It affects 2.6 million older adults annually, and 5 elderly people in the United States in the hospital system become delirious every minute, every day. So if you do the math on that's how we get to 2.6 million older adults. It's a staggering, frightening number. So why is it frightening? I mean, so what? So the patient's pleasantly confused. What's the big deal? It leads to longer hospital stay. It leads to functional decline. And the older I get, the more this terrifies me. So you come into the hospital and you lose the ability to walk, or maybe you've had a catheter and you no longer can protect your bowel or bladder function. If you don't recover that within about 3 months after discharge, it becomes often a permanent impairment. So the functional decline that you get when you're pleasantly confused in the hospital can lead to permanent disability. And that's one of the biggest points that I want to bring out in this talk. It also leads to a whole bunch of undesirable things like risk of aspiration pneumonia, malnutrition. In my case, I'm often called in to help guide people through their care. Should they go for the heart cath? Should they go for the renal ultrasound? But when they're delirious, they're often completely incapable of holding these discussions with you. And if they lack advanced directives or a surrogate decision maker, then you're really left high and dry trying to figure out how to guide this patient's care to the best of their ability. It leads to higher risk for permanent institutionalization. So the risk that they'll go to rehab but never make it out after that Medicare skilled care stay. And this is the one that I think is probably the most terrifying, is that cognitive decline that does not improve within a year is associated with things like PTSD and permanent injury. There is actually a subset of patients who never recover from delirium, especially ICU delirium, and these are often even younger people, so completely different than a geriatric talk. But the risk of permanent cognitive impairment follows almost like a dementia pattern. So there is a lot of research going on looking into that, because of course that would be just catastrophic. And this is the other one, to me the other shocker. In addition, as if it's not enough to have functional decline, risk of permanent institutionalization, should you be lucky enough to recover, that's great, but 22 to 76% of people in the hospital don't recover. They die. The 1-year mortality is up to 40%. The longer you're delirious, the worse the outcome. And this is a staggering number, and I have the reference here, 10 times the mortality of sepsis. We hear a lot about sepsis bundles and infection bundles and SIRS criteria, but to think that delirium is so often under-recognized, under-reported, and under-prevented, and yet it carries 10 times the mortality. To me, that's just a terrifying number. This is my obligatory uber scientific-looking slide, which has some of the data that I'm quoting today. And this is a study that very well known in geriatric and delirium literature. It was published a number of years ago now, but it's probably one of the most powerful studies out there showing the mortality of this. In this particular study, there were 350 patients that were 65 and older. 243 had delirium and about 118 did not. And what you're seeing here on the left, I'll try to highlight this for you, is if you follow out 390 days, so approximately just beyond a year, those who did not get delirium, 90% were still alive at the end of the study. Only 60% were alive if they had had delirium at all during their stay. And that's pretty much what this is showing. The other disturbing characteristic here is that those who had dementia at the outset did a little bit better in terms of outcomes. So you might think that if you have dementia and get delirious, yes, that's a bad thing, but it's even prognostically worse if you got delirious and you didn't have a cognitive diagnosis at baseline. So I think that is worrisome as well. It's expensive. Delirium adds about $2,500 to the cost of every patient. Nearly $7 billion of CMS expenditures are due to delirium, and about $164 billion annually. And these are some of the complications here on the left, which is where these costs come from. So certainly if you're sicker and you go to the unit and you stay longer, you cost more, or if you get readmitted. But the ones down here are often harder to capture and every bit as significant. Think of how many caregivers you're aware of who have quit their jobs to stay home and take care of an ailing parent, or come in and sit in the pre-COVID when patients could have their family members come to the hospital and sit with them. Think of all the time lost from work and from doing other things in order to provide care for that individual. So this is a ridiculously expensive complication. And this is another slide, and Eric Milbrandt was actually my pulmonary and critical, he was a pulmonary critical care fellow at the time that he wrote this study, but he was also my senior resident at St. Vincent's many years ago up in Indianapolis. And one of the people that taught me about delirium when I was just an intern. But in his study here, he demonstrated that basically whether you're in the ICU or whether you're in the hospital, your hospital care is almost double in cost if you get delirious versus if you don't. And that's pretty much what we're showing here. So moving a little bit into the mechanisms and pathophysiology. I don't know on your screen how well this shows up, and therefore I'm just going to walk through this diagram, which I think is probably a little bit shrunken down for you to see. But that's okay, because the point is not to absorb everything on it, but to just kind of highlight there are so many pathways of proposed brain injury which leads to delirium. Everything from neuroinflammation to something called homeostenosis. And the way that I kind of put that into lay terms is reduced cognitive reserve. So somebody who, you take two 65-year-old people, you give them both a bladder infection. One of them gets treated in the outpatient setting, stays home and continues to do her water aerobics and walk her dog every day and take care of herself. The other one gets horribly delirious, ends up in the hospital, in the ICU, in 4-point restraints. What makes one person go down one pathway versus the other? And that is all the different postulates that are on this slide that people are looking at. So something we call homeostenosis. There are many others: oxidative stress, sleep-wake dysregulation. We know that part of being in the hospital means sleeping poorly. It just seems to come with being in a hospital. So sleep dysregulation, we think, can have a profound effect on one's vulnerability to develop delirium. The one I want to highlight in the next few slides is this one in the middle: neurotransmitter dysregulation. We know, we have a lot of data mounting that anticholinergic and dopamine toxicity are very much part of delirium in patients. So I will dive into that a little more in subsequent slides. This is another diagram that I love to use because there are times that people pull me aside in the hallway and say, hey, can I do a curbside consult about this patient that's really confused? And I will almost never do a curbside consult because I'm doing that patient a terrible injustice. because every time I see somebody that's confused in the hospital that I think is delirious, this is the pathway that's going through my little brain trying to figure out and eliminate sequentially, arm after arm after arm, what could be involved and what might not be. When I come back to the case of Mr. M at the end, this is the diagram that I worked through, that I'll kind of walk through when we go through what I found when I went through all of his medical history and situation. But everything from cortisol excess to glutamate activation, GABA, and then we have the cholinergic pathway, dopaminergic pathway, serotonin's involved, as well as cytokines. So there's just so much coming at that sick brain that can contribute. And unfortunately, sometimes patients have multiple pathways all at once. So that's why it's really hard to do the so-called curbside consult when somebody is delirious. And a couple more points I want to make about anticholinergic effect, because I'll come back to this at the very end when I mention medications. But we know that cholinergic transmission declines with age. We know that the cerebral cortex is heavily innervated by cholinergic neurons, especially in a place called the basal forebrain. So the risk of delirium totally correlates with levels of serum anticholinergic levels. And those of you who have had delirium training kind of entrained to you already, you might be very aware of avoiding what we call cholinergic burden, or avoiding medications that can decrease the effects of acetylcholine on the brain. And this is part of that reason, is that we know that these levels, as the level of acetylcholine drops in the aging brain, there is a diminished ability to be independent or to perform one's activities of daily living. We also know the corollary, which is as anticholinergic levels normalize, delirium actually resolves. So that's some of the more profound evidence that we have of how acetylcholine affects delirium incidence. I want to highlight that delirium is a symptom. It's not, don't think of it as a diagnosis. And what do I mean by that? If a patient comes into the emergency room and they're short of breath, it's very typical maybe to rule out an acute coronary syndrome or rule out pneumonia, check a chest x-ray, maybe rule out a blood clot. Let's say you find a pulmonary embolus that was causing that patient's shortness of breath. When you admit them to the hospital, you don't say shortness of breath and add that as their diagnosis throughout the remainder of their stay, do you? I mean, that would be missing the whole picture, right? That would be talking about a symptom, but missing the whole boat that that patient has a pulmonary embolus that needs anticoagulation and appropriate treatment and follow-up. Delirium is the same way. So delirium, think of it as a symptom, because if you don't, then you cognitively close yourself down to saying, well, they're just delirious. It is a sign of something, and it behooves us to figure out what that thing or what those things are. So we shouldn't be writing delirium in the chart every day. We should be writing delirium behavior due to, and then forcing ourselves to find out what that underlying problem really is that's causing it. So when you see somebody that comes to you with an acutely altered mental state or delirium, we think of every patient having a combination of contributing factors. And what I've done here is I've divided them into two columns. On the left are what we call core symptoms, and on the right are associated features. So core symptoms are those things that are pathognomonic to diagnosing delirium: the acute onset, the attention disorder, the altered consciousness, the inability to perceive accurately what's going on around them. Those are the core symptoms. The associated features are things like altered sleep-wake cycle, psychomotor activation, affective problems, autonomic dysregulation or neurophysiologic dysregulation. So these are some of the manifestations that we see that, that become part of the delirium presentation. Oops, I did that again. I'll try to hit the right arrow. So the other thing that I want to mention, and this gets to that pleasantly confused patient that I keep referring to, is that delirium presents in more than one type. So there's the hyperactive or agitated type, and those are the patients that you cannot miss. You're not going to miss this. These are the ones that are actively hallucinating. They're crawling through their bed rails to get up. They're trying to rip out their Foley catheter. They're just acutely agitated. And usually the first thing that happens is somebody will pick up the phone and call the intern to come during the night to provide some kind of medication to help calm the patient. So that you can't miss it. But then there's the other kind that is a mimicker, and that is hypoactive delirium. This is manifest as lethargy, somnolence. This is that patient that can look pleasantly confused. This is the patient that's so overlooked that a seasoned hospitalist who's been addressing delirium her entire career can miss it if I don't intentionally and objectively screen for it. It has the same adverse consequences as the hyperactive form. So it's kind of innate to think, well, if somebody's calm and quiet and confused, that's got to be better than agitated and ripping their line out and screaming and hitting and kicking and biting, right? But it's not. It actually has the same mortality data as the hyperactive form. And that's why I'm going to spend a significant part of this talk talking about how we distinguish hypoactive delirium from other things, because you can imagine it's catastrophic when we miss it. So this is the diagnostic mnemonic that I like to use when teaching med students and residents about delirium, because most of us in geriatrics know what the IADLs are, the instrumental activities of daily living. So if you think of the IADL mnemonic, only in this case, the I stands for inattention, the A stands for acute onset, the D stands for disorganized thinking, and the L stands for level of consciousness change. So to do the confusion assessment method, or the CAM, it takes about 5 minutes of direct interaction with the patient in the hospital. So it might not be the best tool for a busy nurse to do if you want her to assess an entire wing of patients each day and report back to you on who is at risk of delirium. But as a provider, doing that initial intake or that initial assessment of a patient, this is something that is very easily done in the course of our interacting with that patient. And we're going to talk a little bit about how we, some ways we recognize some of these things. But a positive CAM, or a positive screening test for delirium, you have to have the first two features. You must have both of those. And then you have to have either the third or the fourth. You can have both the third and the fourth. In other words, the patient can have all four, but they have to have at least the first two plus one of the others. This is a highly sensitive test. It's really good at, hence it's really good at picking up patients with delirium. It's also fairly specific, 89%. So it's pretty good at ruling out people who aren't delirious when they have a negative CAM. This was developed by Sharon Inouye, who is a mentor of mine from afar. She developed this way back in 1990 when she was actually just completing her geriatric fellowship at Yale. She's at Harvard now. But she has developed tools on delirium which are known on every continent of the globe. So she, this is part of her work, and I'm going to refer to her a little bit later as well. So how do we test inattention? This is one that sometimes learners ask me, so I thought might be appropriate to mention in this talk. You don't have to get too technical here, especially if you're dealing with a patient that you don't think might be very comfortable doing a lot of math or a lot of spelling. I have a lot of patients that might not even have a high school education. So if I ask them to start doing serial sevens, their eyes are going to glaze over at me. But if you give them a series of numbers and say, hey, can you start with 20 and count backwards to 1? Or ask them to give you the days of the week, and assuming that they can do that, then ask them to give them to you in reverse. Or maybe give them 4 or 5 numbers and have them tell you the numbers backwards. But there are many ways that this can be done without requiring the patient to spell things backwards or to do math and calculation. And those are the ones that I usually start with, at least. So this model is one of the oldest models of the kind of showing when I talked about homeostasis, or your cognitive reserve. And what this means is we have the predisposing factors. Those are the things that the patient brings to the table that we can't change. And I'm going to tell you in a minute more about what those are. But then there are the precipitating factors, and that's all the things that happen to the patient. And then it's the intersection of the predisposing and precipitating factors, whereby a patient either ends up doing okay or they don't. And what this table is simply showing, that a patient with very low vulnerability doesn't take much, takes a very low noxious insult to make them delirious. Whereas somebody that has a good cognitive reserve might take a much more significant blow before they develop delirium. And that's just one of the models that's widely reported in the literature. So who is vulnerable? I mentioned this predisposing and precipitating factors. On the left, just think of predisposing as all the factors that we can't necessarily do anything about. If a patient is elderly when they meet us, we can't change that. That's a precipitating factor. We don't know why, which is why I have question marks here, but male gender makes you more vulnerable, as does dementia. If you already have difficulty getting dressed or bathed or taking care of yourself, then you have a 4 times greater risk of developing delirium. Moreover, we have everything from sensory impairment to mental illness, chronic illness, certainly past alcohol and other substance abuse. We can't change any of that. But on the right, we have precipitating factors. And I'm just going to talk right through this. So precipitating factors are all the things that get added to the patient. And I'm not going to mention every one of these, but I am going to highlight that we have, if you add more than 3 medications to a patient during their hospital stay, you have theoretically increased their risk of getting delirious by 4-fold. So all of these conditions basically play a vital role in helping fuel that cognitive reserve problem that patients bring to the table. So let's go back to Mr. M. This was the guy that I mentioned came in with acute confusion, auditory and visual hallucinations, significant weakness, hasn't gotten out of a chair in 40 years, but has an acute decline over approximately 3 days to a week, according to his wife. And I relist the abnormalities that we found on exam. And then I wanted to mention his medications. We're going to come back to these, as I promised. Why might he be delirious? First of all, is he delirious? I hope this is a talk on delirium, so I hope everybody's concluded that he probably is delirious based on the overwhelming amount of features that I presented, which are entirely factual. None of this is made up. Why might he be delirious? So this is an oversimplification of that crazy slide that I showed you that had all these different metabolic pathways coming at it. And this has simplified them into things like infection, reduced blood supply, neuroanatomical changes, neurotransmitter problems, and sedative and analgesic use. So these are all the different areas that I felt really deserved looking into when I looked at Mr. M. These are all the problems that I think he brings to the table. So everything up above, of course, these are predisposing factors. I can't change the fact that he's male, or that he's 71, or that he hasn't moved in 40 years. I can't fix that. But then these are things that are maybe predisposing factors, like the acute kidney injury, the low B12. But then I highlighted only the medicines that could potentially contribute to his presentation. So you'll see that there is not a single medication that's not highlighted. He is on a very high dose of gabapentin, considering his current renal function. He's on a lot of hydroxyzine, which is often used in veterans for PTSD and to help with nightmares and anxiety. I see a lot of this in the VA system. He's on an SSRI, which we know that SSRIs can contribute to falls and difficulty walking and dizziness. He's been taking a rather hefty dose of melatonin too, so that is probably further augmenting his sleep cycle. He's on scheduled long-standing opiates. He's also taking one of the most anticholinergic H2 blockers for his reflux. And he's on high-dose statin, which, as we know, can be not so much, I don't think of as an acute cognitive change, but with the quads and trunk weakness he presents with, that's also something that I'm thinking about. But then there's that little something that his wife says that he's been using to help alleviate head congestion. And to me, this was the icing on the cake. He was using Benadryl or diphenhydramine. And I try to educate patients and families and learners that anything over the counter that has PM in it, like acetaminophen or otherwise known as Tylenol PM or Advil PM, the PM is almost ubiquitously diphenhydramine. So highly anticholinergic antihistamine that can wreak havoc in people. Did this single-handedly affect this patient? I think he had a lot of contributing factors, which I just outlined on the last slide, that certainly were factored in. But then his wife said that he was using roughly 50 milligrams or 2 tablets 2-3 times a day for up to 4 days prior to admission. So I think it was a significant factor. And what I've done here is I've just outlined everything on the left, all of the predisposing factors for Mr. M. Again, those things that he brought to the table, but then all of those precipitating factors. So right at the top is, he was going in his own homeostasis for 40 years in his chair. His opiates hadn't really changed. None of his chronic medicines had really changed. But the addition of this diphenhydramine was that proverbial straw that broke the camel's back. So all of these things were basically going on out of control when I met him. Why is this so difficult then? This is a very illustrious example, but we've talked about how serious it is, how common it is, how it can have horrific effects, including death. Why is it so often overlooked? So I mentioned this before, and now we're going to hit on this in a little more detail. Delirium can masquerade as other things, especially the hypoactive type. So delirium has a huge overlap on the dementia and depression spectrum. So you've got to figure out which is which. And sometimes patients do come to the table with a number of these things going on all at once. And that's why this can be really important, because of course the treatment is dramatically different for every one of them. We also tend to over-rely on technology a little bit. I rarely order head CTs. My joke is that they're almost always done by the time I'm called to the table, because the patient has gotten at least 3 of them between the ER and a couple days into the hospital stay. Rarely will a head CT or any kind of neuroimaging be helpful unless there's truly a history of head trauma, or a objective finding on physical exam, or perhaps the patient, like many patients, is on a blood thinner, and there is a history of them having hit their head. Aside from those compelling reasons, it often doesn't help me very much, other than just saying, yep, it looks okay, or it has chronic changes, and it's hard to attribute those to what we're seeing right in front of us. This is a super fun activity that I'm just going to show you in a picture form. This is a card sort activity that I do with med students and residents, and I usually build this into an afternoon-long workshop, because what I do is for every column and row here that you see, I have a little laminated card, and everybody gets the same stack of cards, and they have to basically figure out whether the card is referencing delirium, dementia, or depression, based on the onset, the attention, the movement, hallucinations, changes in consciousness or attention, effects on sleep, course, and treatment or reversibility. And this can be really hard, but to me the best way to teach this is by doing this card sort activity where everybody kind of works together in pairs. I would have loved to do this today with you all. That is definitely not going to happen given the pandemic isolation that we're in. So I present you the slide that I usually show at the end of the activity, and I'm just going to highlight the delirium features in this first column, which is, again, the onset of this is acute. So unlike dementia and depression, which might take weeks, months, years to evolve, this one comes on much quicker. And attention is very much impaired, as we talked about how to test for attentiveness. The patient could have, increased movement, hyperactivity, be all over the place, or they might be sitting very still, depending on whether they're hyper or hypoactive. And again, you may commonly see hallucinations in delirium, which is not a prominent feature in the other two, in dementia or depression. Often, the sleep cycle was just a hot mess. I think of, people might be everything from sleepy and difficulty to keep awake to not sleeping for days, running through the hallways, basically a nursing staff's worst nightmare. It fluctuates by nature, and the big one, which is leading into the last 15 minutes of the talk, is that there's no medication to cure this. Unlike there are medications to at least mitigate dementia, there are certainly medications that can treat and reverse depression. There is no known medication cure for delirium. So remember, up to a half of all patients with delirium are going to have dementia. It's not always diagnosed ahead of time. So I passionately believe that anybody that gets delirious in the hospital setting that's elderly deserves a follow-up visit in the outpatient setting down the line so that we can assess their cognition under the best of circumstances when they're not sleep deprived and they don't have a Foley catheter and they're not hooked up to antibiotics. But it would be very important for them and their families, as well as just for goals of care and long-term care planning, to determine whether there's any underlying factor that caused them to become delirious to begin with. And again, patients with dementia have up to 5 times the risk of being delirious. So again, they're married. The more delirium you get, the more likely you are to have something going on at baseline and vice versa. So I think for all those reasons, it's very worthwhile to have this looked into when the patient's healed and home from the hospital and better. I talked about much of the workup already in this slide. Things that I just want to highlight is that I do targeted exam, and COVID has been fascinating in that I didn't know what I was going to do as a hospitalist when I was no longer allowed to necessarily see patients face-to-face unless it was considered emergent. Of course, in my world, delirium is a medical emergency. But I've been incredibly successful doing a lot of these consults, even electronically, calling in and talking to people on the phone, carefully observing the chart. Of course, in the outpatient setting, telemedicine can be very helpful, and we're developing telemedicine on the inpatient side as well. But so much of this evaluation comes from observing what's in the chart, what's right in front of you. Again, fancy, expensive neuroimaging doesn't really add a whole lot, and frankly, most of the time it's done by the time I meet the patient. But then the big focus, and this is the one that the pandemic has made a living nightmare, is environmental modification. Adjusting the environment to make it friendly, to make it home-like, to have family and loved ones there. And I'll talk about that a little bit more. Of course, that's really hard to pull off, at least in the spring and summer of 2020. So this is my last couple slides and I mentioned I'd talk a little bit about medicine. So if there are any PharmDs in the audience that have been waiting to hear about medication, this is your moment. So I mentioned that the most common reversible cause of delirium is giving people new medications. It's a cause in up to 40% of hospital cases of delirium. And again, if you add more than 3 drugs, you increase the risk by more than 4-fold. And then I've listed the most common medications, the most common culprits. and the increased risk factor here on the right. So certainly anything that's slated as a psychoactive or sedative hypnotic agent is going to be much more likely to cause delirium than maybe starting somebody on very low dose hydrocodone. But you could see that depending on the agent and the class within the drug class, the risk can vary anywhere from, from 2 up to almost 12% increased risk. So that is why much of the focus is on non-pharmacology or the non-pharmacological ways to prevent delirium. So always treating the underlying disease process. So that, of course, requires trying to figure out what the underlying disease process is. Avoiding other things that can cause delirium. So, hospital environments, this is why they can be so toxic, especially if you're elderly. We don't want your hearing aids to get lost. We don't want your eyeglasses to get lost or your dentures. So you meet people in bed that have no hearing aids, no glasses, no dentures. They can't eat, they can't swallow. Sometimes they're even hard to understand, especially if their mouth is a little dry and they're missing all of their teeth. It can be really hard for us to assess them. And of course, it's really hard for them to follow instructions if they're very deaf and they don't have any of their adaptive devices. So trying to provide adequate lighting in the room, noise control, minimizing interruptions at night, giving them activities to alleviate boredom, like word finds and crossword puzzles, counseling and supporting the family. These are all wholesome, cheap, free things that we can do that don't have side effects. But a world pandemic has made it much more challenging for us to work through this on our end. Don't forget that you're not alone in this. This is really hard work, and it's sometimes depressing work because patients don't always get better like that. So use your interprofessional team around you. Use your nursing staff. Have your pharmacist help you review medication lists and look for offending medications or sometimes offending interactions that you might have missed. Dietitians can be very helpful in identifying food that patients are willing to eat, because most people don't want to eat a low sodium diet. But if you can find something that they find appealing, often giving them something to eat and encouraging them to continue feeding themselves can go a long way to preventing functional loss. And then, of course, everybody else in the hospital, the social workers, the case managers, the patient's family, all of these are paramount important to helping us. So this gets to, I told you I was going to mention Sharon Inouye at least one more time in the talk. And this was a study done over 20 years ago now. This is back in 1999. But this was her big randomized controlled trial where she took basically matched cohorts of patients and caregivers. All the patients were over 70. They were not delirious at admission, but they were deemed to have a really high risk of developing delirium. And what she did was she developed a paid caregiver system called HELP. And what HELP did was it provided basically everything that you see in this column, every risk factor for delirium. She provided an interdisciplinary team member that was a paid volunteer to work on addressing every one of these. So walking the patient to keep them mobile in the hospital, which also kept them from falling asleep all day long so that they were more likely to rest at night. Making sure they had something to see with and hear. Early recognition of dehydration and making sure that patients weren't just sort of dwindling on the vine. This cost about $300 per patient. And when you think in terms of the day of a hospital stay, or God forbid an ICU stay, $300 per patient is nothing to a healthcare system if you have now helped that patient get out of the hospital earlier and better. And certainly it's nothing when you think in terms of grandma's alive at the end of the year versus not alive, or maybe institutionalized in a nursing home. So this was a hugely successful study. Why doesn't every hospital have a HELP system? Because it's hard convincing people upstream and paying volunteers and finding volunteers. It's a hard program, but we're trying to do it at UAB, we're trying to do it at the VA, and there are many places across the nation that are trying to do, if not help, there are other things. And there are some resources online. If you Google Sharon Inouye, and her name is at the bottom of the slide here, help COVID, there are free resources plastered on the internet that you can download and use to help implement these kind of processes with your patients, even in this horrible time that we're in right now, where we can't have people just traipsing in and out of the hospital room trying to help keep our patients cognitively intact. And she reduced delirium by 40% in this study, which is staggering. So let's talk in the last 5 minutes about the pharmacology. This is the pharmacology, tumbleweeds in the desert. So this is going back maybe 40 years of research, and this is pretty much what we know. There's a paucity of evidence. Haloperidol is the most often studied, probably because it's one of the oldest first-generation antipsychotics. Think of, if there's one thing that you take away from this slide or from this talk in terms of pharmacological treatment of delirium, remember that we will, and I will, use medicines to induce sedation when somebody is so combative and so exhausted and so uncontrollable that we need to help them calm down and everything else has failed. But do not fool yourselves into thinking that you're treating the underlying condition. So I hear this all the time. We gave the patient quetiapine, they got really sleepy, and when we came back later, they were no longer tugging at their catheter. We have done nothing to treat the delirium. What we've done is we've treated the symptom. Symptomatically, they're no longer combative, but now what we've done is we've converted them into a hypoactive delirium. So just remember that medicines can and should be used judiciously when needed, but don't fool yourself into thinking that you're making the patient better. Always use the lowest doses and go slowly. Couple other pointers I want to mention. You always want to start with the lowest dose of the shortest acting medicine. If you give super long acting medicines and the patient has an iatrogenic response or a paradoxical response, you can't take that back. You have to wait for it to wear off. So we always start with the short-acting agents. And I always say, you can always give more. Most medications reach a Tmax in the bloodstream within about a half an hour if they're given IM or IV. If you reassess the patient within 20 minutes to 30 minutes and they haven't even budged, you can always give a little bit more, but you can't undo it. We always avoid benzos unless you're truly convinced you're treating withdrawal. I mentioned a couple of tools in the tool bag. I've used just generic names here. And I mean, just to bring my point home, these are the kind of little baby, like I tell people, what I call my 95-year-old little old lady doses. These are tiny doses, but sometimes that is all you need. What often happens is a stacked dose of 4 milligrams gets given, and then in 15 minutes, another 4 milligrams. Well, I mentioned that the Tmax, or I'm sorry, the Cmax, the maximum concentration, you're going to get that in about 30 minutes. So if you've repeated it 3 times over in that time, all of a sudden the patient is going to finally pass out. And then sometimes they will sleep for days, and then I get called back because the patient's not arousable. So this is why that geriatric mantra of start low and go slow, but go. And then I mentioned some just commonly used atypical agents here and starting doses. I also want to just give that word of caution when using anything that's QT prolonging, like your atypical antipsychotics, and extrapyramidal effects. We need to be careful, watch out for all of these. Things like neuroleptic malignant syndrome. And there are a lot of medicines that can contribute to this that are not necessarily intuitive. And this is where your PharmD can help you by doing a good medication review. But another thing is these things, by their very nature of reducing the sensorium, they increase the risk of aspiration. They increase falls. Again, they do not help cure the underlying delirium, they only slow it down. And then there's that nasty black box warning of atypical agents that they can cause sudden death in patients with cardiovascular disease or vascular dementia. So whenever I'm using these agents in patients, I feel an obligation to discuss with their families and caregivers about this side effect. And sometimes we choose to use it when the risk-benefit ratio points in that direction. But sometimes we decide it's not worth the risk. So I think that that's important to keep in mind. This is your last resort. You never want to tie the patient down. Why do we see this? Because sometimes everything that I just mentioned in the last 55 minutes hasn't kicked in yet, hasn't worked. And sometimes patients truly are at risk, especially in an ICU setting where they might have a difficult airway and the last thing you want them to do is to rip out their endotracheal tube. Sometimes restraints are used, but again, we want this to be the last resort and not one of the first things that is reached for. And then one little slide on delirium prevention, because sometimes I get asked this as a question, is there any science that we can give these medicines ahead of time to people that we know have vulnerability to prevent this from happening to begin with? And my quick answer is not a lot. So there is some mixed evidence, but overall our guiding bodies in geriatrics and internal medicine and psychiatry guide us to not use antipsychotics as a preventive strategy because we just don't have the evidence. The same goes for benzos unless you're dealing with recognized methamphetamine or alcohol withdrawal. Cholinesterase inhibitors, I've seen some patients get proactively put on things like donepezil, which is a dementia medicine, first of all, not to be started on the inpatient setting, but second of all, no proof that it does anything with underlying management of delirium. I will use melatonin agonists every once in a while because mostly just melatonin because it's cheap, it's readily available, we have it on our formulary, and it can be part of what I think of as almost a homeopathic means of improving sleep hygiene. So I don't give it at bedtime, but I might have them give it at dinner time or give it a couple hours before bed, accompanied by all those wonderful Sharon Inouye things of turning off the light at night, turning off the TV, avoiding loud conversations out in the hallway, all of those things. There's no evidence that corticosteroids, statins, or gabapentin prevent delirium. There is a little bit of evidence that maybe reducing the amount of perioperative sedation that you give a patient might have better outcomes, and for that reason we try to avoid, or let me rephrase that, we try to give the patient the least amount that they need when going for a procedure or surgery because we at least theoretically believe that that will lead to a better outcome. So my take-home points: delirium is common, it's serious, it causes mortality. It's the end result of all of those precipitating features, but then predisposing factors that get stacked on. IADL is for me, a nice, easy way of teaching the confusion assessment methods so that you always remember all the parts in all the right orders. You're going to miss it if you don't look for it, especially the hypoactive form. Even people that have done this decades, you're going to miss it if you don't look for it. It's kind of like looking at a patient and predicting who's going to have orthostatic hypotension and who's not. You kind of don't necessarily know until you check it. It is distinguishable from the other Ds, from dementia and depression, but it might take a good bit of effort, and it might take repeated evaluations and getting reports from various people. It is preventable, and it's preventable especially with doing good, non-expensive, low-hanging fruit kind of things to make the patient feel like they're in a more holistic, home-like environment, which can be very challenging to pull off, especially during a pandemic, especially in an ICU setting where maybe repeated vitals and repeated assessments are necessary. So the best treatment is prevention. And interventions that emphasize that non-pharmacologic approach. So I want to end with Mr. M. What did we do for him? We did extensive family education about over-the-counter meds. We eliminated some of his medications, primarily the diphenhydramine that he'd been taking. We greatly altered his gabapentin dose. We got rid of the ranitidine because he said he didn't need it anyway. We scheduled Tylenol. We actually chose to continue his oxycodone because he had been on this for years, and we felt that he was in considerable pain as well. And I felt that this was probably not a significant contributing factor because his renal function recovered very quickly. So we kept that going. We repleted the B12. We got his hearing aids fixed. We put them in. He's actually wearing them. We had sleep medicine titrate his CPAP so that he could tolerate it. We ordered short-term inpatient rehab after the hospital. And he has an appointment, his appointment was set up to follow up with me in 3 to 4 months, which is coming up anytime now. And I'm going to try to do it by telemedicine so that I can try to do a repeat slums and assess him. But on the very final day, I didn't know their med student was going to do this. He was in the hospital for 5 days. On his very last day, the med student went back in, morbidly curious, and repeated his entire cognitive workup. And his slums, remember it was 10, right? It was 10. Look at that, 26 out of 30. He had almost completely normalized his cognitive function just with the implementations that we did during that hospital admission. His hallucinations were gone. He looked like a completely different human being. So I think that this is a feel-good moment. We don't always get this kind of response, but this is what we can hope to be attained if we recognize it early, recognize all the precipitating factors, and address them. So I hope that one will never use the term pleasantly confused in a chart again. I actually found this when I was preparing this talk, something called the Nurses of Instagram. I love this adorable little llama, but aside from cute little llama memes, I hope that we won't label people pleasantly confused, because there is nothing pleasant about being delirious. So this is where I would normally take questions, and I think there's going to be an ability for you to write in, and then all of your questions can be collated, and I think that they'll get to me, and I'll be able to answer them later on. And I'm sorry I didn't get to see everybody in person, but thank you for viewing.
Okay, whenever you get ready, you can start.
Hello, my name is David Rogers, and I'm delighted to have this opportunity to speak to you about a topic I think that's really important to me. As a way of background, I'm a pediatric general surgeon. I'm still practicing in half of my effort, and I was lucky enough to be one of the early individuals designated as a chief wellness officer at UAB Medicine, and so we've had a couple of years of thinking about wellness in the healthcare arena. And so today's presentation is I want to just provide some background, but also some suggestions for people that lead teams. I'll show you in a few moments some information that motivates that approach, but ultimately it's my experience and my contention is that the frontline leaders in healthcare are the ones that really make a big difference. It's fine for people in the C-suite to be supportive of this, but really it's the frontline leaders that make a difference. And frankly, in my experience, having been a frontline leader, one of the things we do poorly in healthcare is equip those same leaders with the skills and the abilities that they need to effectively lead. At least as a physician, typically we take a really good surgeon or in a scientific arena, a good scientist, and we just elevate them to become the leader without much training and preparation. So the purpose of this talk is to really speak to people that lead teams, but also people that are in teams, because that's how we do healthcare. I always say in this conversation that the great unifying perspective is the patient perspective. And I've been lucky that I've been healthy most of my life, but I've been a patient and I've been the family member of a patient, and I can tell you that those people really want us at the top of our game. And so that's really my motivation to share with you some of my thinking around this topic of wellness today. So the specific educational objectives is I want to talk a little bit about some basic definitions of stress, burnout, resilience, and engagement, and then try to relate those constructs. I think this is important because a lot of these topics have become common in the vernacular, and so anybody you stop today will talk about that they're burned out. And actually there are specific meanings around these ideas. And so I just want to talk a little bit about that so that you'll be better equipped to have conversations around these topics. Talk a little bit about some of the models in healthcare, particularly about what is driving so many people into burnout, and then what are the outcomes as it relates to the individuals and to our patients. I'll give you some ideas about an approach to team wellness. A lot of them are based around general science, and some are related to specific research in healthcare. And then finally, try to give you some resources that will help your healthcare team reduce stress and improve resilience. I don't have any financial relationships or affiliations to disclose, and I won't be talking about medications, but the things I will be talking about, I won't be promoting their use in an off-label way. So this is the optimal state of human existence, that particularly our focus is about the workplace, but really you could extend this out to your general life. So any job has particular challenges, psychological, social, physical challenges. So if you're an ICU nurse, then their psychological challenges when you have conflict with other members of the team, or challenges with getting the support you need, or with a difficult patient, or even a difficult social circumstance. There are also social challenges that can relate to that network. And then I think a thing that I didn't understand coming into healthcare is that there are physical challenges. So I'm a pediatric surgeon. Most of the cases I do are fairly short cases, but if a case goes on for many hours, there actually are physical demands related to the work that we do. And clearly that's true for people that are medical assistants, nursing assistants for nurses, pharmacists. There is a physical aspect of that we don't often talk about. What we hope is that there are resources that match those demands, so psychological, social, and physical resources. And when we have things in their proper arrangement, then people are in a state of well-being. There's an interesting argument in the sociological literature about, does the word well-being need to have a hyphen in it, or can it just be one word as featured on this slide, which to me suggests that while that's not unimportant, that there are people worried about things that are different than what you and I are worried about. This is a really good model, I think, of what happens in life. So we go along in this state of well-being. In this particular model, you can see that well-being is described as biopsychospiritual homeostasis. So the point there is that, again, you're in this state of balance. Biologically relates to the physical demands, the psychological demands. So all it takes is one really difficult family interaction or a patient death that puts you out of that state of well-being and into disruption. And so you can see in the top rectangle of the slide that this idea of stressors. So we would be fine if we didn't have adversity and stress or life events that occur to us. But even having a colleague decide to leave a position activates all of this and becomes disruptive. We then enter into a state of disruption and then can progress into a type of reintegration. Some people actually emerge from a period of adversity much stronger and more resilient than they went into it. And in fact, a lot of the studies related to resilient adults studies children that grow up in very challenging circumstances. So imagine a child that grows up in deep deprivation, in deep poverty, children who grow up in active war zones. These are people that, if they survive, can be amazingly resilient individuals. A lot of people then get back to homeostasis, so they get restored, but then some people don't ever fully reintegrate. In other words, they never get back to the state of biopsychospiritual homeostasis, and they then can enter into a state of reintegration with loss, or actually dysfunctional reintegration. So the words are different, but this idea of reintegration of loss, that one of the things that I think about is that we know kind of the cost of burnout to the organization, but what we don't know is what is the cost of disengagement when people just can't come back. They kind of lose their enthusiasm for the work that they're doing and trying to improve it. So that then leads to the next question of what is stress, and this is from Oxford Dictionary, kind of just a dictionary level definition of it, and it's a state of mental or emotional strain. And I really like the fact that they've included both, and I would suggest that both typically occur, but this idea of strain, because that's what it feels like, resulting from adverse, and again, we're back to that topic of adversity or demanding circumstances. There's quite a bit of literature about the neural effects of chronic stress, and I took some time a couple of years ago to try to dive into that. I'm a pediatric general surgeon, and so I'm not a mental health expert, I'm not a neuroscientist, and so I've had to consume it like any of you would consume it. I'm certainly not an expert in it. In fact, I often remark that if I'm on the airplane and they say, is there a healthcare provider on the plane, that unless it's an infant with a hernia, I'm not going to be much good. So I've really become hyper-specialized. Nonetheless, in looking at this literature, it's very concerning literature, because what it shows generally is that there are actual structural and biochemical effects to your brain if you're in a situation of chronic stress. And so using functional MRI, they've actually shown that parts of your brain, particularly the prefrontal cortex, will actually thin, which makes you less able to navigate through future stress. Other aspects of your midbrain, high brain, the amygdala, which is very important for your immediate response, actually enlarges. And so you can see a biologic equivalent of a pathway that people can end up in where they can exhibit signs of, for example, post-traumatic stress disorder, which is marked by a very sort of exaggerated response to a stress. And so you can see that the biology very much corresponds to what we observe behaviorally, and that people's brains are actually changing. And that's really quite concerning to me, because it then means that people are going to be less well capable of dealing with future stresses. And you can see this pathway that people can be on where they can become substantially and maybe impaired on the long term. One of the consequences then, as we think holistically about our colleagues, is that I don't have a work brain and a home brain. So if my brain is being changed in a structural way because of my work stress, I'm going to take that home and I'm going to take that out into the world. And that's going to make me less able to adapt to stress that's coming from my home. I have sons in their 20s, and a lot of times they're my major source of stress as they navigate through to adulthood. But my work-related stress then affects my ability to deal with stress that comes from different places. I think you could summarize it to say that the neural effects of chronic stress definitely lead to long-term personal and professional consequences, and therefore I think we really have to pay attention to it. This is just a slide that gives really kind of around these same ideas. This is not from the medical literature. This is just general organizational research. And the reason is that I've selected this because there are also examples of this from healthcare, is that even though we're in healthcare, we're still people too. And so this has been studied in other jobs that are very stressful. So there are physical consequences, and you can see this is quite a long list to it. Some of it includes things like obesity, coronary artery disease, and these, I think, are a chronic consequence of a chronic activation of your stress system. You remember that we form epinephrine in the short term and then cortisol in the long term. And so high levels of cortisol related to workplace stress can definitely cause these physical consequences that you can see featured on the slide. Psychological consequences, as you can see, depressive symptoms. I was at one time approaching burnout. What happened to me is I was in a small Catholic hospital where we were trying to set up a women and children's center, and one day the last remaining sister in the system called me on a Sunday and said, you need to come to the operating room. And I was like, well, sister, this is my Sunday off, and so why would I do that? And she said, well, your partner just collapsed in the operating room. And so I agreed with her, yes, sister, I think I should come down. And that, we navigated through that acute thing, but then the consequence was I became the lone remaining pediatric surgeon, and so went on for months and months. And I remember one day trying to write parenteral nutrition for an infant, which can be a little challenging, but I remembered that I had lost the capacity to add and subtract. And I remember thinking, this is not good if your surgeon cannot add and subtract. And so I think those are some of the psychological cognition-related things that just happen when you're sufficiently fatigued. And it feels a lot like depression in terms of just your enthusiasm for the work and your capacity to kind of get up and deal with the patient problems, which are what bring us into healthcare to begin with. And then particularly if you're a team leader, some of these occupational consequences, so this idea of presenteeism, which is this idea that people are coming, but they're not contributing new ideas, they're not acting with enthusiasm, they're just simply there kind of doing their thing, trying to get through that day. But even absenteeism, where they begin to call in because they're genuinely unwell. This then is how stress then relates to this very contemporary problem of burnout. And this is brand new science. It was originally described in 1919, so a little over 100 years ago. And that is, we've known that there's a relationship between stress and human performance. From an educational standpoint, we actually know that you want your learners somewhere in the mid-range. We don't want learners that are bored because we're not asking them any questions or doing anything. That's not really our challenge in healthcare. Our challenge in healthcare is I think we've had too much of our population in a chronic state of distress. And so you see more on that end of the curve where we're beginning to see ill health and breakdown as people have just been asked to perform in a situation which is not attentive and not supportive for way too long. This is Christina Maslach, and she's the one that originally described burnout. So again, to try to get some precision about what we mean when we say burnout. Burnout, as she described it originally about 30 years ago, is a state characterized by emotional exhaustion, low self-efficacy, and depersonalization. So emotional exhaustion has been the most consistent finding, and that is the part, at least in my experience, that feels like depression. I remember having a resident call me and saying, I have a great case. And I remember thinking, in my state of thinking, there is no great case. And to me, that is a sign you're in trouble when the things that have always, gotten you excited and joyful about healthcare are no longer doing that. Low self-efficacy is interesting because that means that I don't feel right, but somehow I don't feel like I have the energy to fix this. Or probably reflecting my own generational view, I don't feel right, but I can just power through this. Maybe if I was a mental health provider, I would have understood that sooner, but you can't power through this, just like you can't kind of claw your way out of a true clinical depression. And then depersonalization, which is a less frequent finding, is when I no longer have the compassion to see you as a person. I'm just seeing you as a task to be completed. And so that's the sign. And I think that it probably very much relates to some of the things you saw about absenteeism, lack of stability, but even disruptive behavior. You can definitely see a pathway where the things would be connected. What we've tried to do in our thinking is to try to attach the ideas of burnout and engagement. And so while we definitely want to reduce burnout, we also want to promote engagement. And the way that these can be conceptually linked is that burnout is the idea of emotional exhaustion and depersonalization and abiding sense of failure. And so the three main themes there are that of energy, involvement, and efficacy. No matter who you lead, I think you would agree that you would be happy if on any day the people that are on your team show up and they're vigorous and they're connected and they're competent. So the point of all this is we're not trying to just reduce burnout, we're also trying to improve engagement. And the two are distinctly related. A lot of times when I'm looking for photographs to try to illustrate points, I just type them into a search engine and see what pops up. If you type in resilience, you get 500 versions of this flower growing out of a rock. I'd challenge you to do it. You can probably do it on your phone as you're listening to this presentation. But for some reason, it is the generally accepted metaphor for resilience. And I think it's right. It's the idea that you can flourish in a difficult circumstance. So I have two definitions here. The top one is from the American Psychological Association. It's the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. And what I like about that definition is it relates it to the idea of adversity, but also then relates it again to this chronic stress, which I think is a main driver that we're having in healthcare. The second definition is actually from the pediatric psychiatry literature, and it's the process to harness resources in order to sustain well-being. And the reason I like to show that one is it, to me, is a fairly hopeful idea that there are some things that we can do to improve our own resilience, which offers us a pathway to well-being. Now let me make it clear, at least at UAB Medicine, it is not our organizational strategy to ask our providers and staff to be more resilient. To me, it has to be a part of it while the organization is looking to restructure our work in a way so that it is less stressful. In other words, I think the organization has an ethical obligation to try to make our work as stress-less as possible. The advantages of resilience is it's something you can start immediately, and I'll show you a framework for doing that. So you can start this today and have an immediate benefit, whereas changing things organizationally take a great long time. The other reason that I would recommend it is it works if your stress is coming from life as well. So I use it, as I mentioned, with my own family. If my stress is coming from them, resilience training helps me deal with that as well. So those are the two really good reasons, I think, to pay attention to resilience, particularly since I think there's some simple things that you can do to improve it. This is kind of how we've ended up in the situation where we've ended. So UAB Medicine is a part of a thing called the National Academy of Medicine Collaborative on Clinician Well-Being. This group has representations from pharmacy, national pharmacy organizations, nursing, respiratory therapy. A lot of different groups have representation here. And so they've put together these sort of contributors to the situation. You can see they're just hundreds of them. And so they relate to external factors, those that occur outside the organization, those that are occurring within the organization, and then individual factors. So people have an individual tendency toward burnout that may relate to their background or personality or kind of just their way of thinking. In the U.S., these are some major drivers of physician burnout, and you can see, and I've observed this in the 25, 30 years that I've been around the clinical environment, that we've just seen layering on layering of additional regulations as we've sort of experimented in our own uniquely American way with our healthcare system. And so you've seen all of these things that have been layered on really in the last 25 years. And to me, as I just watch the world that I live in, this is the big difference from when I was a medical student to now, that when I was a medical student, the attending seemed to have time to teach and time to be available to do things like mentoring. Now everybody just seems incredibly busy all the time, very toxically busy. And I think that these regulations are to account for part of that. And this, of course, for providers, whether they're physicians or advanced practice providers, anybody who's using the electronic healthcare system identifies that as a major problem or major contributor. And you can see the cartoon here says our new electronic health record system is so easy to use and dependable that we don't even provide training or tech support. Just sign here and it's all yours. While that's funny-ish, I think it makes a point that the electronic health record itself was a flawed endeavor from the onset. It was never designed to facilitate patient care. It was really developed as a financial tool from the onset. It's never sort of championed usability or the consumer experience for those of us who are trying to use it. But the other part is organizations then may have been overly optimistic when they adopted these systems in terms of saying, great, we can remove clerical support, we can remove other support because we have this magical tool. And to me, I feel like that we all deserve criticism in retrospect for not having thought about this a bit more, recognizing that the federal government got involved and mandated some of this to have to occur too quickly. So for example, many of the senior faculty at UAB don't type. And so we then instituted a system that requires you interact with it through a keyboard. And why didn't we think about the person-machine interface before we just compelled these things on an entire population? We're now experimenting with voice interfaces that are much better, but that's taken 15 years to sort of get to that point. So this was clearly technology that wasn't ready for prime time. And we, I don't think as organizations, thought about what was going to be the demand of people having to learn a whole new different way of doing things. This is why I think the frontline leaders are critically important and why you can begin to make a difference today. And this again just shows that a lot of these sources of stress, some of them are coming from a societal stress. I'm fairly apolitical, but I would think we would argue that our government leaders have really made decisions in managing the pandemic that have certainly brought a lot of stress for those of us who are in the front line of healthcare. Those are societal considerations and we don't control them. There are organizational choices that are made that I think are within our control. And at least in my role, I definitely advocate a lot for that to be a part of our conversation at the senior or C-suite level. But then the microsystems, I think, is the thing that most substantially impacts people's everyday experience. And so if you have a really good leader, I can put you in a difficult circumstance, and I think your welfare is at a whole different level than if you have a leader who's not capable. And so that's why I think these frontline leaders are really important and why I was delighted to be able to speak to so many of you today. The rest of this model then just shows how all of that plays out and ultimately the impacts of the provider-student wellness, but even things like quality improvement and safety, patient satisfaction. You will only take your organization so far in terms of patient satisfaction, experience, and quality if you don't attend to the well-being of your providers and staff. This is from the secular, sort of non-healthcare literature. This is a thing from the Gallup that showed that the immediate leader, here called the manager, accounts for 70% of the variance in employee engagement, which is gigantic. I mean, it just means it's having a tremendous impact on those people. This is an interesting study that was done around nurses specifically, and what they basically did is to ask them their satisfaction with different aspects of the job. And so they then subcategorize it into better work environment, mixed work environment, and poor work environment. And so for senior leadership who can many times become very focused on money, one of the interesting aspects of this is it shows that people will actually be satisfied with less money if you produce a better work environment. And so it shows that actually organizationally you can probably save money by equipping your frontline leaders to be more effective in what they do. It just shows the huge impact that your everyday manager or leader has on your work experience. And this is what the nursing work environment looked like. These are frontline nurses in a variety of different settings, but what they are looking for in their leader is managerial support for nursing, which is this idea of advocating for the nurses, helping to solve problems that nurses are encountering, actually getting down and sort of joining in the work to provide a really powerful example for people that are doing the work. And then this idea of responsiveness to correcting problems that people, I've observed, get very cynical if they come to their leader and say, we have this problem, and they're just told nothing we can do, just deal with it the best you can. And then as a physician, I have to acknowledge that people in my tribe, the physicians, are a big cause of nursing stress. And therefore, a nursing manager needs to be able to seek out physicians and call us to task, or at least point out the effect that we're having on the nurses in that unit, or at the very least know to escalate this to the next level of nursing leadership so it can be addressed. I think too often in healthcare we excuse negative behavior on the part of physicians, and it's something we need to address as we go forward. So that then moves me to the really last part of the presentation, and that's trying to give you some practical suggestions for what you could begin to do for your immediate team. And some of this is based around our own experience. Some of it's based around some really good research literature. I would characterize that the state of our understanding of burnout in healthcare is we know what's driving it, but fixing it is a whole nother matter. And I think we're only beginning to see some very early efforts in trying to help people manage stress and recover from burnout and promote engagement. Nonetheless, I don't want to make this a purely theoretical presentation, and so I did want to give you some practical tips that you could at least begin to experiment with. I've experimented with all of them myself and found them to be fairly helpful. And the reason I think this is important, and I realize that the audience is scattered throughout the Ascension system, but this is kind of what we're looking at in Alabama. I think some of you in the Northeast have had the advantage of having moved very quickly, and so you're seeing decreasing numbers. But here in the South, where the projection is we're going to continue to see deaths mount through the fall. And some of that will depend on the severity of the influenza virus, and so this may be worse. Here in Alabama, we've really struggled with people wearing masks. It's become a very political issue. We do see some change there that political leaders in both parties are now acknowledging that wearing masks is something that we need to be doing. But nonetheless, my prediction is this fall is going to be challenging on into the winter. I, like many of you, are praying for the vaccine to be effective and come sooner rather than later. But I think it would be a little too sort of optimistic to think that we're not going to have a challenge through the late summer and fall. So the first thing that I think leaders need to do is track your own well-being, and that is the analogy many times is used that you need to, when you go to a code, the first thing you need to do is check your own pulse. And the idea is if I'm not good, then I can't take care of my team, and so I have to have a sense of my well-being. The tool that we like to use is based around this work done at Mayo Clinic by an investigator named Lottie Derby, who's a physician, really superb researcher, and she identified a 9-item well-being index to identify distress. My understanding from an interaction I had with Ascension Network leadership is that they're offering this in some of the organizations. If you have an opportunity to take it, I would recommend it. I take it monthly, just sort of to track myself. This is how it works. You get an email at a frequency of your choice, including we should never be bothered with this again. You answer 9 easy questions. It really takes less than a minute. And then you get a dashboard that looks something like this, and it will kind of give you areas where you are doing well and some areas where you probably need to pay attention to. And so, as I mentioned, it also then attaches you to local resources. One of the things that we found is that there are actually lots of people in a large organization like UAB that are already thinking about this. So some real important collaborators for us have been our HR professionals. They've been thinking about this for a lot longer than I have, and they already had accumulated some tools that we were able to use. We've also found particular groups in our mental health community that are very helpful. One of the things that we have in our organization that I think every organization needs to have is someone that it's safe to go talk to, that it doesn't have to be reported, just to kind of talk through, like, this is what I'm feeling, what do you think is going on, what can I do about it, but a completely confidential way for people to interact. That doesn't have to be a mental health expert. I think there is some value if you have psychologists available for them to do that. But I think a lot of people were like I was, and they know something's wrong, but they don't have an understanding of it, and so they just feel stuck. Or in my case, you know, I picked the wrong strategy where I thought I could just outwork it, and trust me, you can't. So in this system, you get this dashboard, and as I mentioned, I track it monthly, and I can definitely see for my own self that there have been times where my well-being begins to lapse a little bit, and that prompts me then to reassess my life, and maybe I've been too busy, or maybe there are really good reasons for this, but it causes me to pay attention to the things that cause me stress. So if you don't have access to that, my alternative tracking recommendation goes back to my childhood. I grew up in Florida, where we have a lot of tannic acid in the water, so it's that deep brown color. And so the concern about that is if you ever are out swimming in a river and you go under the water, it's difficult for people to find you and rescue you. So we were always advised of the importance of having a buddy. In my own case, it was because I didn't have access to anything like the well-being index. It took a friend of mine coming to me and saying, you know, you're not good. You're not bad, but you're not good. You're not excited about the things that you know, you used to get excited about, and so what's going on? And that caused me then to take the burnout inventory and realize what was happening, and then to take actions to try to change it. So I would say if everybody had a buddy, healthcare would be a better place. Somebody who just has said, hey, it's your job to kind of keep an eye on them. If they notice that they're getting a little grumpy or they're not, you know, behaving in the usual way, it's okay to reach out. And this is the idea behind leader wellness self-care. The other analogy behind taking your own pulse is if you don't put the oxygen on yourself, you can't help anybody else. And so I'll talk in a minute about, we're trying to think about leader well-being, but the first thing we do is check on the leader themselves, because if a leader is burned out, and if you're a senior leader, this may relate to people that are in your mid-level group. If they're burned out, then we really think that it's cruelty to go to them to ask them to do more. This is another thing you can do, and that is there are some behavioral approaches. We picked some, this one by Amit Sood on the bottom of this slide, because it had really good positive effects. And so in an academic medical center, we're going to get a lot of skepticism. This is the model, and so since you're in a Catholic healthcare system, you'll see none of this is particularly new information. People have been practicing some of these things for thousands of years, but gratitude, compassion, acceptance, meaning, Forgiveness is very helpful, I think, particularly if you're a nurse and I've done something ridiculous, then take the opportunity on Friday to just forgive me, and then having some time to rest and reflect. This is gratitude. It started at calling 3 blessings. It's now called 3 good things, and it's just the exercise of at the end of every day or maybe in the morning saying, what are 3 things that I'm really grateful for? I like to do it in the morning when I wake up. So if I wake up and I had a good night's rest and I'm in a climate-controlled environment and everything's still working, then that's 3 good things. I'm already off to a good start, and I find that it tends to put your mind in a different place. The other thing I like to do is at the end of the day before I go home is I'll ask the question, what went well? Because I tend to be perfectionistic and I'll perseverate around things that were difficult, and this causes me to think about things that went well that day. This is here in Alabama, and this is a thing called the Boll Weevil Monument, and it was erected by the farmers who recognized that when the boll weevil came to South Alabama, it compelled them to move away from cotton and to diversify, particularly into peanuts, which has been very lucrative for them. And so they erected a monument to an insect, recognizing that that adversity caused them to take a positive change. So there's not a lot of other reasons to go to Enterprise, but if you're ever down in that part of Alabama, it's just a good reminder that we can be grateful even in the midst of adversity to realize good things will come. These are Amit Sood's 2 books. The one about stress-free living has the full model. The Handbook for Happiness is really a kind of a 4-step handbook or workbook that goes with it. I'd recommend it. You can see how happy the people are, so it clearly works. So I'd recommend it to you. As an overall leadership approach, what we all need to become is what are called empowering leaders, and you can see that that's been studied in the bottom of the slide. And these are people that are genuinely for the development of the people who work for them. So I think a lot about nursing. My sister's a nurse, and so I've heard a lot about that culture, but a nurse manager who isn't just trying to keep the slots filled, but who's actually thinking about the new graduate nurses and how can I help you develop and become the best worker, best nurse that you can be. Tate Shannenfeld published things around specific behaviors, but if you look at them, they're largely the same things. And that is, does a leader really for me and want to help me? So I would recommend that you take one of these challenges. I like the gratitude challenge, and just say, what can we do as a team? If we find that we're in our staff meetings and we're just doing a lot of complaining, or where I hear it's the surgeon's lounge, is can we just say, hey, what are you grateful for? What are you happy about? What's working well? And then promoting compassion. This is the UAB values, and you can see one of those is always care. I'm sure Ascension feels the same way. And I think what I'd challenge you to think about is we're really good at taking care of our patients, but I think we could do better in taking care of each other and ourselves. There's a lot of incivility in healthcare that I think we need to address as leaders. And then this one I include, it's a little scary, but that's a suicide prevention hotline. If someone comes to you and actually expresses that I think I'm going to kill myself, that you should take that seriously, not dismiss it. One thing that's been shown is to thank them. Thank you for sharing that with me. Who else have you shared this with? Because it's been shown that having a social network actually decreases the likelihood they'll act on it. But here's a 1-800 number and some other things that you can do. And then ultimately, we have to advocate up the system and begin to look for better developed systems that support our team and ourselves. So this is our little logo that we developed, and we tried to pick up on this physical, psychological, and social. But we've indicated that the pathway there is through occupation, intellectual efforts, health efforts, emotional efforts, but also very importantly, spiritual efforts. So all those things are really important. I think they're going to collect questions from you, so I'll have a chance to respond, but here's my email address. If you'd like a copy of this presentation, I think they're going to post it so you'll be able to see it, but I'm happy to interact with you if you'd like. I'm sorry I won't be able to see you in person. I am impressed that the system has moved to a distributed system. It's really, I'm grateful for the work of promoting wellness, although some days it's tough because we're trying to do a lot of culture change. But I hope you'll join me in the effort and just think about one or two things that you can do as a leader. I think you'll help a lot of people on your team. And so that's my great joy in sort of sharing some of these simple suggestions. So thank you very much.